Hello everyone and welcome to our webinar presentation, Webinar Wednesday that is. We're here streaming from our Woodlands Clinic, which is one of the locations that today's presenter sees her patients, the other one being Spring. And in honor of Colorectal Cancer Awareness Month, we're talking preventing, treating, and beating colorectal cancer. Meet today's presenter, Dr. Sheila Chandra. Dr. Chandra is coming up on her 4th anniversary with Kelsey-Seybold Clinic, and we're glad she's been here for that many years. She's certified in internal medicine as well as in gastroenterology. When she isn't caring for patients, you can find her teaching her med students at Baylor College of Medicine. And also, please know that you can submit your questions during the webinar as soon as you think of them, and Dr. Chandra will answer them during the Q&A session at the end of the presentation. So go ahead and start filling those out as you think of them, and we will catch them when we get to that portion of the webinar. And now, here's Dr. Chandra.
Welcome, everybody. This is Sheila Chandra. I'm very glad to be part of this webinar. It's a pet project of mine, a favorite topic of mine, and a very important topic, I think. Before we get started off, a few common facts about colon cancer. It's one of the most commonly diagnosed cancers. It is the second leading cause of death in the United States. It is preventable, treatable, and beatable in most cases with early detection. We don't do very well with early detection because half the people in the country don't get screened. So we have about close to 42 million patients who are eligible for screening haven't gotten a screening colonoscopy. So both men and women are at high risk, men a little more than women. Lot of data about baby aspirin reducing the risk of heart disease. Along with that, we do see some protection for colorectal cancer. A high fiber diet is considered beneficial. How common is this, and why do we care so much about colon cancer? Look at this incidence of colon cancer as you get older. There is a big bump of colorectal cancer at age 50 to 54. And then as you progress to the last decades of your life, it's the highest incidence. So your lifetime risk of colon cancer is about 1 in 10 or so. And a third of patients who are over age 50 do have polyps which need to be removed, and they can turn into cancer. So our colonoscopy screening guidelines are based basically on these increasing incidence of colon cancer with age. It's a disease of old age. Occasionally, though, we do see colon cancer in younger patients who have a genetic predisposition to this disease. So how does colon cancer develop, and how do we have time to find and prevent colon cancer? See, colon cancer in most cases is a very slow-growing disease. So the way the cancer starts and finishes is it starts from a normal colon lining. There happens to be some genetic mutation which takes place, which forms a small polyp. The polyp continues to grow, and then it turns into cancer. The whole process takes about, on an average, 7 to 10 years. And this gives us time to do our screening protocols as to prevent and find cancer early and prevent death. So this is a picture basically showing a normal colon mucus on the top. Then you see a very small, maybe a 5-6 millimeter adenoma, which is, again, the process has already begun. So there has been some loss of, or a mutation of an APC gene which caused an adenoma to form. And this adenoma continues to grow bigger and bigger and then turns into cancer. How common are polyps with age, and how do we know these polyps turn into cancer is a big question. This is what we know. The graph of the polyps of the colon follow the graph of the cancer of the colon. Most colon cancers seem to come from these pre-existing polyps. Most colon cancers also seem to grow very slowly. So when you look at this graph, as you age, the incidence of polyps increase. And when you're 50 plus or 80 plus, about a third to a fourth of patients do have polyps. These polyps, a lot of them are precancerous, and the whole idea of doing the colonoscopy is to remove these polyps so they don't turn into cancer. Most patients ask me, what are the symptoms of colon cancer? You know, it is a very silent disease. It's a silent killer. The colon is a big organ. It's about 5 to 6 foot long. It's broad. It's very roomy. So if you have a little growth in your colon, you're not going to have problems. You have problems only when the colon cancer is so big, or it's spreading to the other areas, or it's bleeding. So no symptoms actually is very, very common. You can have sort of vague abdominal pain. You can have excessive gas. You can have change in bowel movements, rectal bleeding, anemia, weight loss. All these usually are later symptoms of colon cancer. Which comes to the question that how can we protect ourselves from this deadly disease, basically. So traditionally what we see is we see more colon cancer in areas and countries where we do a high protein, high red meat diet, less fruits and vegetables, processed meats. All these seem to play a role in colon cancer development. So it's a combination of your genetic makeup. It is a combination of what you eat and drink, and put them together with, what predisposition you have to colon cancer. So basically diets of fresh fruits and vegetables, good physical activity, so you don't get very obese, which increases the risk of colon cancer. Some protection are seen with aspirin and NSAIDs. Calcium and vitamin D seems to be protective. But there is no one dietary thing which can protect you from colon cancer completely. So in terms of inheritances of colon cancer, what we do know is about 70% of colon cancer are non-genetic predisposed, or we do not understand the genetic predisposition in these cases. In about 10%, we know, they have an APC gene mutation, they have, family polyposis syndromes, and they get colon cancer. There are another about 25% of sporadic colon cancer. I don't think we understand it as well. This comes in the group of patients who have some family history of colon cancer, first-degree relative, second-degree relative, and it seems to increase their risk, and we don't understand their genetics as well. In terms of medications to prevent colon cancer, well, no medication currently is approved by the FDA to prevent colon cancer. There is no such one single pill you can take and say you're going to prevent colon cancer. But there are some medications which have been shown protection. And when you look at the risk-benefit ratio, patients who have genetic polyposis syndrome may benefit with using, NSAIDs of different kind. And it has been shown in some studies to protect them up to about 30 to 40%. But these studies also did show a slightly increase in cardiac risk in these patients because of these medications. So something to be used with caution. Again, here there is a small list of, what may increase your risk and what may decrease your risk. None of these things have shown a cause-effect relationship, though. All these are probably related. We know that there is a link, but we're not sure as to how strong the link is. So basically lack of physical activity, red meat, obesity, cigarette smoking, alcohol, all the, things which increase other diseases also seem to increase colon cancer. Again, aspirin, NSAIDs, postmenopausal hormone use carried a lot of weight a little while ago, but now with all the side effects of post-hormonal hormone use, we kind of shy away from recommending that. Calcium, selenium, vegetables, fruit, fiber, etc. What I do say is stop taking food or meat out of your freezer, eat fresh as much as you can, and I'm pretty positive that helps. Symptoms are common in late cancers. Depending on the location of the cancer and what it's doing, you can get different symptoms. Your rectal cancer, usually you have symptoms earlier on. You'll see rectal fullness, urgency, bleeding, painful bowel movements. On the right cancer, usually the cancer is caught a little late. You can see anemia, weight loss, and some kind of vague abdominal pain. On the left side, again, you can also see obstructive cancers. Cancers happen all over the place. Earlier, we used to do only flex SIGs to screen for cancer, look at half or quarter of the colon, and now we've realized that a full colonoscopy is really the gold standard. So why do we need to find these cancers early, and how much of a difference does it make? A huge difference. And in terms of colon cancer, we are in the best country to be. We have the best survival rates for colon cancer compared to the rest of the world. So you should do the screening colonoscopy to find these cancers, preferably in stage 0 or 1. So your survival rate at 5 years is 90%, which is really, really good. There are very few cancers we can expect these kind of survival rates. And as the cancer advances, your survival rates go down and your treatment intensity also goes up. So it is very important to find these cancers very early. Who are the candidates for screening? All women and men over age 50 should be screened. Anybody who's healthy enough, who's going to live 10 years, should be screened. Patients with family history should be screened earlier. Patients who have inflammatory bowel disease should be screened earlier. And also, you should screen patients with genetic polyposis syndromes earlier. So bottom line is, everybody over 50 needs to get one screening colonoscopy. It's important because it probably could save your life. See, what the problem we run into colonoscopy and screening is half the people don't come for screening. Common question I get asked is, I'm doing well, I'm not having any problems, why should I come for your screening? And then you tell them, it is a silent disease and it is the, third common cancer and second common cause of death, so you should do it. So to give you an idea as to how discordant we are about our screening procedures, 90% of the women go and have their pap smears. Cervical cancer is way less common than colon cancer. In national statistics, only half the people who need to be screened are getting screened. So we are screening more patients than we did about 20 years ago. We are screening and finding more cancers now than we did before. We are doing way better in preventing cancer death from colon cancer now than we did even 10 years ago. So, the death is declining, and we believe it's the effect of colon cancer screening. Gold standard for screening is colonoscopy. So what is a colonoscopy? We basically take a fiber optic tube, evaluates the entire colon. We basically look at the entire colon. We look at polyps. If we find any, we remove them. This is one thing which has been shown to reduce the risk of colon cancer development. It is not 100%, but it reduces it on an average, about 60 to 70%. There is a lot of data about right, left side cancer. It reduces more of left side cancer than right side cancer, and there's a lot of debate about this which is going on. The bottom line is, there is not one other screening test which reduces risk of cancer to this extent. There are some newer tools to screen for colon cancer which have been in the news. One is virtual colonoscopy, which is nothing but a CT scan of the colon. Then we can do stool DNA testing. We can do blood testing markers for HNPCC. Most of these, except the virtual colonoscopy, is ready for prime time. But the rest of the genetic testing, the FIT testing, all of these are not available widely, and it's not ready for prime time yet. Kelsey-Seybold has a very simple and a unique plan to streamline patients who can come into colon cancer screening, meaning if you're healthy, you have no other medical problems, you're doing well, and all you need is a screening colonoscopy, you do not have to come for a pre-consult appointment with your GI doctor. What you can do is request your primary doctor for an appointment for direct colonoscopy, and the process is streamlined. A nurse will call you, she'll evaluate you, whether you're a good candidate for that process, and the next time you meet, your GI doctor will be on the exam table. Generally, one of the few concerns about this is, does the GI doctor know me? The GI doctor would have reviewed your file, and she also will do a quick physical exam and a history on the table before she, does the procedure on you. So in terms of safety, efficacy, it works. So we talked a bit about the fecal occult blood testing. Most of them have done it. You take these cards home, you put some 3 stool samples in there, bring them back, it's tested for blood, and if it's positive, we say for BT positive, you need a screening colonoscopy. One caution though, when you do screening tests, if you do fecal occult blood testing every year and then you do a colonoscopy the next year, don't do the fecal occult blood testing frequently every year. It's either fecal occult blood testing every year or colonoscopy every 10 years. Then barium enema used to be very commonly done before. It's not a favorite of mine. I think it misses a lot of lesions. I think virtual colonoscopy is practically taken over that. Flexible sigmoidoscopy is where you look about a third of the colon. Used to be very popular before. We don't do it as much because to me it seems like you're examining, you're doing a mammogram in one breast. You know, it seems like you're leaving half the colon, not examining it. It doesn't make sense to me. So colonoscopy is definitely the gold standard. Virtual colonoscopy is an upcoming, very useful tool. The results are quite comparable to traditional colonoscopy. What it is basically a dedicated CT scan of your colon. So you do need to prep for the colonoscopy just like you would for the colonoscopy. We introduce air into the bowels through a rectal tube. If polyps are found during this test, then you would need a traditional colonoscopy, meaning you will have to re-prep, you will have to do the whole thing over again. So in healthy people, it may not make sense to do the virtual colonoscopy, and also most insurances do not approve that. But in patients who, for whatever reason, cannot undergo the traditional colonoscopy, that's a viable option. And one other caution of this procedure of late is a lot of radiation exposure, which we are getting more and more concerned with. These are some pictures of colon polyps. The first one on the left top is a small adenoma. When we say large adenoma in terms of colon polyp language, anything over 1 centimeter we consider a significant size. On the right side you see some cecal adenoma, which is flat. You see a lot of polyps in this colon in the right bottom, which is in a patient with familial adenomatous polyposis. And on the left bottom is how your normal healthy colon should look like. So as we were talking about colonoscopy, it's very simple. You take a flexible tube with a light in the corner. You pass it to the end of the colon. We look to remove polyps. We biopsy if we see anything abnormal. We look for colitis, look for any other kind of abnormal, structure of the colon. Nowadays, we are very aggressive with the colonoscopy. There are huge, big polyps which we remove just through colonoscopy. 10 years ago, these patients required surgery. Now, not anymore. We do remove these polyps. Anything that can be removed endoscopically is removed endoscopically nowadays. Ideally, colonoscopy should be done every 10 years in patients who are healthy and over 50, and more frequently if you find polyps or if you find issues. This is what the scope looks like. This is just a stethoscope. I thought it was a scope. Never mind. You will be given instructions that'll explain to you how you need to clean the colon out. The colon is a big organ filled with stool. So, a lot of patients tell me, I'm not eating all day. Is it okay? I'll come for the scope. Oh, no, you have to clean out. I have to be able to look at the walls of the colon. That's the most important part. The colon is a long organ with lots of hiding spaces for polyps. So the clean out has to be really, really good. So you're on a liquid diet the day before. You will drink a bunch of liquids, which is going to make you, it's like a cathartic, it's like a free colon cleansing of sorts. So you're going to go to the washroom a whole lot and clean your entire colon out. You try not to take anything dark colored so it doesn't mess with the endoscopic view. You need to let your doctor know if you're on any special medications, you're on any special blood thinners. It's very important for your doctor to know, because when you cut polyps, you can bleed from those spots. When you come into the day of the procedure, they will change you. They will start an IV line, and then you will give you medications so that you can be comfortable during the procedure. You will not be able to work or drive that day. The following day, you'll be definitely back to normal. So bottom line is, screening does decrease death from colon cancer. Screening can lead to removal of polyps before they're malignant, and it helps to diagnose cancer very early and helps to improve survival of colon cancer. So this is how we are doing. This is the most recent data we have nationally. You can see that Texas is somewhere in the 50% range, which seems to be the national average. We definitely can do better than this. Some common questions I get asked a lot when we tell any patient you have a precancerous polyp, and I get 5 phone calls about, does that mean I have cancer? No, it does not. It means that you do have polyps which are benign, but which can have the potential to turn into cancer. And again, big question about I don't have symptoms. Do I really need to have colon cancer screening? As we discussed many times today, people with colon cancer can be completely asymptomatic. So it's a very silent disease. That does not mean you do not need colon cancer screening. And colon cancer in early stages is definitely curable. Survival rates are very good. So it is important to find the cancer as early as you can. But if it so happens that we find it at a slightly later stage, there are still very good treatment options available. Colonoscopy is not just a screening tool. It is a preventive tool too. There's not one other screening test which actually prevents cancer like colonoscopy does. So it does both removing polyp and also screening for polyps. You do hear a lot of horror stories about colonoscopies. You hear it from the neighbors. You hear it from the, you tend to hear the bad stories and not the good ones. Colonoscopy is not that hard. The hard part is probably what you do at home to clean out. There are different options of preps you can use to make it, tolerable to each person. Each person is very difficult. And during the procedure, most patients actually don't remember much at all. And a common reaction I do get after the procedure is this is it, this was it, and we're done, and that's it. And they come back for the next colonoscopy. So we try to make it as pleasant as it can be so, people don't not come for the next one. And this cartoon does not happen nowadays, I promise. Thank you for your time. I'll be happy to take questions. I see a question which is asked here. It says, I've had a colonoscopy at age 50. When do I get another one? If your colonoscopy at age 50 was normal, and if it was complete and your prep was adequate, and they removed no polyps, your next one should be in 10 years. If it was an incomplete procedure for whatever reason, you may need to have a colonoscopy done sooner. If you have a family history again, or if you had polyps, you need to have it done sooner. How soon depends on what polyps they removed and how many polyps they removed. Next question I have here is, when polyps are removed during colonoscopy, doesn't that reduce your chance of colon cancer as you age? Yes. That is the whole basis of colon cancer screening. So what we are trying to do is remove these polyps which have the potential of turning into cancer. So yes, it does reduce your risk of colon cancer development during that age, as you get older. But the problem we run into is some colons form polyps. So what we are trying to do with these screening surveillance protocols is to go in there as these polyps come up and remove them. We're trying to balance the risk of procedure and the risk of these polyps growing and turning into something not nice or nasty. So we're trying to balance those, and that is the whole basis of screening programs, like how soon to go back, how soon not to go back. If you go back into the colon too frequently, then you haven't given enough time for the colon polyps to grow, but I have put the person under risk of an unnecessary procedure. So you want to space them out at, depending on what we find. If colon cancer is in our family, how early should someone do a screening? So general rule of thumb is if you have a first-degree relative with colon cancer, say father, mother, brother, sister with colon cancer, you start screening about 10 years before the youngest member with colon cancer. For example, if somebody is diagnosed with colon cancer as a first-degree relative at age 50, the screening in those family members should start at age 40. The next question is, if there is no family history of colon cancer, should a colonoscopy be done? Absolutely. If you're over 50 years old, you definitely need to have a colonoscopy done, even if you don't have a family history. That is 70% of colon cancers diagnosed today are people without a family history. If you had polyps removed and then 10-year follow-up was clear, are you then on the 10-year cycle? It is a little difficult with this question. Generally, if you have a history of polyps which were precancerous, traditionally you can go about 5 to 10 years. We tend to lean towards 5 years. The reason being, your colon has a tendency to make polyps. So 10 years may be a very long time and the polyps may have grown pretty big. So you can make a case for both, but I tend to lean towards 5 years. The next question I have is, if someone has IBS or any other abdominal and bowel changes after having colonoscopy about 2 years ago, do you suggest another colonoscopy? It depends on what the symptoms are. What I do suggest for this person is to go see a gastroenterologist so that they can assess the symptoms and review the previous colonoscopy as to what they found and how they found, and check out to see if there's any other symptom concerning. So some of the symptoms of IBS do overlap with colon cancer, and the big concern for a lot of patients who are younger who have IBS symptoms is, do I have colon cancer? More than likely they do not. And the symptoms are so vague. So a lot of times we do review your previous colonoscopy report, and then if we don't do it just for the sake of doing it because it's not going to make the IBS any better, we do it if there is a clinical indication to do it. A question here. My younger sister died last year of stage 4 colon cancer. She had been having some abdominal pain for some time and had not gone to the doctor because of lack of affordable insurance. I had a colonoscopy at age 50. I will be 53 this year. The doctor removed 5 polyps from me and they were not cancerous. I also have a constant uncomfortable feeling in my lower abdomen and more gas over the last few years than ever. How often should we test it, and what do I need to be on a lookout for? I didn't get the age of your sister with colon cancer, but if you had a colonoscopy at age 50 and then they removed 5 polyps, and if all 5 of them were precancerous, meaning they were tubular adenomas or polyps with the potential to turn into cancer, I would repeat your colonoscopy in 3 years. And one of the other things is you can also have an overlay of IBS symptoms going on, so it may be helpful to you to go see a gastroenterologist where they can treat you for your IBS symptoms and then continue surveying your colon. But yeah, I would recommend for about 3 years. I am getting a little bit of blood after stool if I clean the paper thoroughly. I will not get blood if I do not rub thoroughly. I do not get bleeding if I use water. Is there anything that I need to worry about? How often should I get a colonoscopy? I have the following: IBS, hiatal hernia, GERD, gastritis, inflammation. I guess those are 2 different questions. Anyways, for the first question, I guess I would gently clean, and if you have persistent symptoms, and if you're over 50 years old, you definitely should have a colonoscopy. If you're younger than 50 years old and if you're having persistent bleeding, go see a gastroenterologist where they can check to see if you've got hemorrhoids, you've got a fissure, or what exactly is causing your bleeding. The next question I have is, how often should I get colonoscopy? I have the following: IBS, hiatal hernia, GERD, gastritis, inflammation. Again, it depends on how old you are. If you're over 50 years old, you follow the regular protocol for colonoscopy. If you do not have a family history, you're 50, you do 1, and if it's normal, you do it every 10 years. If you have polyps, then you will have the next one sooner, depending on how many polyps, what kind of polyps, etc. This one? Okay. Thank you. Thank you, everybody. It's been fun.
Okay, Dr. Chandra, thank you so much for joining us today, and thank you to everybody who tuned in. Please make sure you join us next month in April when our downtown spring and main campus chiropractor, Dr. Pringle, will be talking about back, neck, and joint pain. Let's get cracking. You can go ahead and register now at kelsey-seybold.com/webinars. In fact, you can register for everything for the entire year if you want to. And make sure that you check us out on Twitter, Facebook, and YouTube. All right, everyone. Thank you very much. Have a good rest of the week.